And we'll pull up my presentation. Again, thank you for having me, and very excited to be here and to learn about everything that is going on in Montana. We've worked with Montana for quite a long time. While he's pulling up my presentation, basically what I'm gonna talk about today is sort of a general approach to inclusion, specifically in the National Diabetes Prevention Program, and to a lesser extent, SNAP-Ed, and talk about a general approach using those programs and those activities as examples. If that makes sense. So, I'll also introduce you to a couple of our colleagues who are with us today, who are actively involved in helping us with these initiatives. And for some of you, particularly those of you who are in the recent summit in DC at Special Olympics, you've heard a lot of this before. But for others who are particularly in public health and not as much disability, this might be new. So,
Chris, I'm just gonna pull it up for my email.
Okay. I can start off a little bit just telling you about where I'm from while they're pulling up the slides. The Lakeshore Foundation, and I have a slide on this, but Lakeshore Foundation is a nonprofit 501c3. We're based in Birmingham, Alabama, where it's much warmer. Whole special kind of cold up here. That's right. And so we are a nonprofit. We're on a 45-acre campus. We are a Paralympic and Olympic training center. We are also a fully accessible fitness center and membership facility. And our membership is, I think, about 4,000 members now, and it's entirely either people with physical disabilities or older adults. Seniors over age 60, I believe, is the membership that we have. We have a variety of things that we do. As we said, was said earlier, we are a partner with the National Center on Health, Physical Activity, and Disability, which is based at the University of Alabama, Birmingham, right up the road from us, and kind of was the start of how we got into this work. But Lakeshore is also we do programming, we do sports programming, adapted sports programming, recreation program for people with disabilities. We are the home of USA Wheelchair Rugby and USA Boccia, or Bocce. And so that's our function as a Paralympic training center. We are home to the Lakeshore Sports Science and Performance Center, where we look at, great, clicker. Let's see. There we go. Okay, so this is the Lakeshore slide. So we do sports programming. We are home to the Sports Science and Performance Center, where we do sort of high performance training and testing with primarily wheelchair athletes. We are also home, and this is sort of a spin-off of our work with the National Center. We're home to where I'm based, which is our community health department. And what we basically do there is look at health and wellness from a public health perspective, and look to include more people with disabilities, or include people with disabilities into health promotion and public health programming. Does that make sense? I babble a lot, so I'm just going to ask you, does that make sense a lot? But in a nutshell, that's what we do at Lakeshore. So what I'm going to kind of talk about, didn't know I kept that one, but this is just examples of some of the things that we do in our facility. So again, we have tennis courts, indoor track, fitness center, and it's all fully and completely accessible. Basically, like if you go into our pool, any kind of accessible entrance that you can think of, we have it. So really, this is kind of putting universal design into practice fully, really. Let's see. And actually, this is number is a little bit old as well, but The reason why we're here, we all know, and we know that people with disabilities experience health disparities. This number actually, if I remember correctly, was recently updated. I think as of July, the CDC now counts 70 million people in the United States have a disability. So the people with disabilities are the largest minority group in the world, cut across all other minority groups, and have disparities across the board compared to people without disabilities. Higher rates of obesity, higher rates of diabetes, and significantly higher rates of diabetes. I think it's maybe twice as high rates of diabetes as compared to people without disabilities. So this is kind of why we do what we do, why inclusion is so important, and why you are all here. To really look at how do you make, what can you do, and I do emphasize do, to make sure that people with disabilities are not forgotten in your programming and have the right and the chance to be healthy. So wanted to kind of start off and just kind of look at a perspective and set the stage for how to really approach inclusion in anything really, but really specifically public health and health promotion programming. And this is the approach that we take and want to encourage everyone to kind of think in these terms when you're planning for inclusion in your own programs. So typically when we talk about disability, we talk about it in terms of the medical model of disability. Disability is a problem within the person. I have spina bifida, I can't walk, and therefore I can't participate. So the problem is within me. And so to get rid of the problem, that means I need to have a special program, or I need to, basically people think about curing disability. Does that make sense? Okay, so we think of disability more along the lines of a disease rather than the social model of disability. This is the approach that you really need, and that we take, and that you really need to take when you're talking about inclusion for persons with disabilities of all kinds. And I do understand there is a strong focus during the summit on persons with intellectual and developmental disabilities. What I'm going to talk about is sort of a cross-disability focus, but with a little bit more emphasis on individuals with intellectual and developmental disabilities. But the other perspective, and the one that you should be taking, is the social model of disability. Basically, social model says that disability is a result of environments that don't support a person's different level of functioning. So medical model says Chris can't participate because he has spina bifida. So social model says Chris can't participate because the program's not accessible to him. Make sense? It's very simple. If I'm explaining it, I promise it's very simple if I'm talking about it. So that is the perspective, really focusing on what can your program do to change and become more inclusive and accessible to people with disabilities. Oh, I think this is an old one. So this is a definition of inclusion that we have used for many years within our work with the National Center, and just as we continue our work with partners in inclusive public health. So inclusion means to transform communities based on social justice principles in which all community members are presumed competent, are recruited and welcomed as valued members of their community, fully participate and learn with their peers, and experience reciprocal social relationships. Basically, inclusion is when it's based on social justice principles. It's based on fairness. It's not fair that someone with a disability automatically gets excluded from public health programming. And so if you are practicing inclusion properly, someone can contribute, and you assume that from the beginning. Someone can learn, and someone can experience all of the same benefits that somebody who doesn't have a disability can in a program. Make sense? Okay. Inclusion domains. Okay, so this is kind of diving right into the how-to of inclusion. This is an approach that we have used within Lakeshore when we are looking at adapting programs specifically, like the National Diabetes Prevention Program and like SNAP Ed programs. And basically, this is a framework that is, you don't have to remember this, but it's another acronym. We're in public health. It is based on a framework called the GRADES, or the Guidelines, Recommendations, Adaptations for Including Disability. And that's why you don't want to try and remember that, because it's one of those annoying acronyms. Basically, this is a project that was developed several years ago. It came from a project that was done several years ago. And it was an attempt to look at CDC's 24 obesity prevention strategies and adapt them to make them more inclusive. And so basically what was developed was a tool for adapting those obesity prevention strategies to make them more inclusive. What also came from this project was this framework for adapting evidence-based programs. And within this framework, we have 5 domains or areas that you look at when you are trying to make a program more inclusive. Does that make sense? Okay. So that's the built environment, services, instruction, equipment and technology, and policy. And I'll kind of give examples of each. Built environment, and this is actually a presentation that was for more focused on smoking cessation, but so you'll see examples in here. But the built environment is the brick and mortar space. It is the building that you're in. It is the bathrooms. It is the parking. It is the ramps and all of those things that we think about when we talk about ADA compliance, Americans with Disabilities Act compliance. Basically, it's kind of everything that if you turn the building upside down, everything that fell out is not the built environment. It's kind of the brick and mortar. Okay, make sense? Okay. Instruction is anything that anybody learns. And that can be anything that a lifestyle coach for DPP learns. It could be anything that your participants learn. It could also be anything that their, I'll say, support system learns. For many people, particularly for people with intellectual disabilities, they rely on others for transportation, cooking, shopping, different things like that. And so including them in programming is often a critical strategy for many people. So, but examples of instruction could be, as a lifestyle coach or a site coordinator for DPP, you learn how to do an accessibility review of your site. You learn about effective communication. All right, adapt and improvise, overcome, right? All right. Right. Yeah, that's the equipment is coming up actually. So that is, again, anything that anybody learns can be considered instruction. Yeah, Yeah, so I'll keep going. There are other domains that are very closely related and overlapping this, but as long as that makes sense, I will continue. Services, person-to-person assistance or other assistance that increases participation. So that is anything like accessible transportation, a personal assistant or an aide, sign language interpretation. Remember, by law, programs are required to provide effective communication. So that could mean an ASL interpreter, for example. Providing health education materials in alternate formats. That could be Braille, that could be large print, it could be very simple plain language formats. So more visuals, less text, which I think for many people would be very useful. And then one of the things that we often do with our programming is campaigns, which is a very primary function of public health. So making sure that when you are doing campaigns around diabetes prevention or advertising your program or SNAP Ed programs, making sure that one, what your messaging is accessible to people with disabilities, and two, that people with disabilities can see themselves in those messages. So, and I mean literally. So do I see somebody who looks like me in those messaging, in that messaging? So those are examples of different services that can be part of your programming. Equipment and technology is another domain. So that you're fine, I'll just use this. That is kind of all the gadgets and things that sometimes break. So accessible phone apps, lifts on transit buses, weight scales. I'll point that out because we're talking a lot about DPP. This is one of the big, with our work with the diabetes prevention program, this is one of the big barriers. And I mean, both in terms of procurement and cost. This is one of the things that you have to plan for, okay? It is not equitable if you're in a weight loss program and, for example, everyone in the program can use a standing scale, but the person with the wheelchair, you know, they have to go see their doctor or have to go to a rehab center or somewhere else where there is a available wheelchair scale. And you're not going to keep them in the program if they have to do that anyway. Does that make sense? So that one I would really point out with this. And then assistive listening devices for meetings like this or classes. Oftentimes those are useful for people who have hearing loss. And accessible websites. That's something that often gets overlooked. So WCAG is the Worldwide Web Content Accessibility Guidelines. Blah, blah. And those, along with what is called Section 508 standards, those are just two different sets of guidance for making websites and information technology accessible. So something that often gets overlooked and important to pay attention to. Policy, laws, rules, regulations, protocols, procedures designed to guide or influence behavior. So that can be big P and little p policy, as we say. Big P policy would be things like compliance with the Americans with Disabilities Act, where you're doing accessibility reviews. It could be making sure your website is accessible or in compliance with Section 508 of the Rehabilitation Act. That's again, has to do with website accessibility. Little p are the rules that you kind of set for yourself. Do you do regular accessibility reviews? Have you identified partners? Extremely important that you identify partners from the disability community. Extremely important. Have you identified people with disabilities who could be, for example, on your leadership in your organization or on an advisory board or something like that? Getting direct input from people with disabilities is paramount. I would put that at the top of the list for all of the programming that you do. And yeah, so basically little p is just kind of those things that you, as an organization that aren't necessarily legally required, that you do on a regular basis to remain inclusive. I'm going to skip that one. And then sustainability. I think we all kind of understand what sustainability is, but really what you need to do is put all of these inclusion practices and techniques into practice on a regular basis, okay? And so, how are you building your skills around inclusion? Where are you finding are you finding partners? Are you finding partners on a regular basis? Are you enshrining inclusion into your policies and procedures as requirements? Does that make sense? So are you requiring staff to understand what accessibility looks like, to understand what effective communication is, how to adapt what they specifically do so that people with disabilities can participate? Does it make sense? Okay. Okay. These are a few resources from Lakeshore and from previous work that we've done. Commit to Inclusion is a website. It's a website and it's an online campaign that we did several years ago with many different partners. And basically it is the foundation of it is a set of 9 guidelines for disability inclusion. And what it helps you do is understand what to look at. And it's very similar to the 5 inclusion domains for programs that I mentioned. It kind of gives you some direction on what to look at when you're looking at community-wide policies and programs in terms of inclusion. And it also provides you an opportunity to pledge, go online and pledge publicly sort of what your organization will do to promote inclusion. Then there's, for those of you who don't know, at the CDC, and who is also the funder, this is the branch that's the funder of the disability and health programs that Meg mentioned. There is the disability and health branch, and that's where you can find a lot of information about data, health disparity data, what's going on in terms of health promotion and public health programming across the country. So those are, and I realize this is like a lot of links, and so I think we can provide this. And actually, I actually prepared a different presentation that has a couple other resources that I think will be useful to you. But we can definitely share these resources or these slides with you. And then at Lakeshore, we did invite a couple of disability advocates to share with us their thoughts and provide some kind of TED Talk sort of format presentations on what their perspectives are on disability and what their perspectives are on ableism, which is one of those isms that we don't often talk about. Before I get to questions and answers too, this is actually a different presentation, but one of that I've done previously, but one of the resources that I wanted to mention was that there are actually a couple of guides and let me back up. There's a guide and a curriculum I wanted to mention. we have, with our partnership with NICPAD, we have a guide on creating inclusion in SNAP Ed programs, okay? And yes. Oh, you have it? Okay, so, and can you hold that up so people can see? Yeah, and you have it in your folder on their tables, okay. And essentially, this is a adaptation of a USDA document. And we applied our 5 inclusion domains to it. And it essentially looks at all of, I think, 5 different areas of SNAP Ed programming and provides general guidance on how to make those kinds of programming inclusive. So that's one resource that is available online through the National Center on Health, Physical Activity, and Disability. The other program that I'll make sure you have my current slides for this. The other program is actually a curriculum that I've been very involved with over the past 7 or 8 years in terms of the National Diabetes Prevention Program. We do have a program called Prevent T2 for All, and it is an approved CDC curriculum for essentially what it's intended to be is an inclusive diabetes prevention program curriculum, okay? What we did was we took those 5 grades or inclusion domains and applied them to the Prevent T2, which is the sort of flagship curriculum for the CDC, and created what we call Prevent T2 for All. And it really is just embedding inclusion tips and strategies into the Prevent T2, the original program for both the lifestyle coach and, of course, for the participants. So what we've done over the past 5 or 6 years is work with, we have a couple of our colleagues from the National Association of Chronic Disease Directors here. We had a grant, it's called a 1705 grant, and essentially used that program across 5 different states and found that it did work. We did see weight loss and within the required, I think, still 5 to 7% for the CDC. And I think what we did find too, though, that it worked better for people with mobility and sensory disabilities, not as much for people with intellectual disabilities. So one of the things that we are doing currently with our friends from Special Olympics is taking our Prevent T2 for All and adapting that again to make it more inclusive and more accessible to people with intellectual and developmental disabilities. We just started that process, and to Special Olympics credit, they are involving CDC from the beginning. And as we're kind of doing all of the adaptations and creating the program in phases and kind of inviting them to come along and kind of take their temperature a little bit and see what they think and see if if they have any tips, and hopefully what we have at the end of the day, at the end of actually next year, is a program that's a lot more user-friendly, more accessible for people with intellectual disabilities. So just wanted to kind of make you aware of those programs. I told them I would point them out. So we have Katie Kakal and Katie Stone in the back of the room. They're our friends from the NACDD that are with us today. And they have been a great supporter of inclusive public health practice and chronic disease prevention practice. And NACDD is one of those groups that CDC will listen to, as is Special Olympics. So just stay tuned, I guess is what I would say. All right. Again, so I will make sure everybody has the presentation with the 2 resources on it, and take any questions you might have. Thank you.
Is it on? Yeah. And can we get the lapel and then I'll run the mic for questions for Chris? We're waiting for the lapel and, oh, it's right here. Is it working? Okay. Here you go, Chris. Thanks. How many of you are familiar with the diabetes prevention program? Is that a program that's familiar to folks? So it might help just to start with just sharing a little bit about the diabetes prevention program. And Chris, while you're putting the mic on, is there anybody from the program who is a lifestyle coach who wants to just share for folks who do not know about this wonderful program in Montana, about the program here? Great, thanks. Yay! Look at me getting my steps. Okay.
So I work with DPHHS through the state. I am a trained lifestyle coach, partly just because I'm the one who in Montana facilitates the trainings for our coaches. So I do have a certificate. I am trained, but I don't personally do the programs. But the diabetes prevention program, we've had it in Montana since 2008. We were one of the early states to kind of work with the CDC to get it going. We just got a couple new sites. I think we have 23 sites across the state who deliver the DPP. We were really excited. They actually started their first class this week. I don't know how many of you are familiar with LIFT in Billings, but they just started their first diabetes prevention program. And they work with people with disabilities and older adults. So we are really excited about that. But the diabetes prevention program, it's a year-long program that teaches, the coaches facilitate nutrition information and physical activity with the participants. It's not you have to do this, like it's kind of giving them that knowledge so that they can make those decisions on their own. It's a group class, which is really nice. People are able to learn from each other throughout the program. The goal is for the participants to get 150 minutes of physical activity a week. And is there any specific? I don't know.
I can add to that if you.
It depends on the location. Some do it for free. Others might charge like a $50 to $100 fee for it. It is a covered expense by Montana Medicaid though, and Medicare. Yeah. So, yep. So she's asking how we track the data to see if we're reaching people with disabilities. So one nice thing in the state of Montana, we have created a data tracking system that all of our DPP programs across the state use. And we do collect the 6 disability questions in there. So we are able to see what type of disabilities are being served with the program. We were kind of excited. We've been collecting the disability questions for years. CDC just in July started requiring those questions to be collected by all programs across the country, but Montana was ahead of the game and we've been collecting that for years.
I am told we're about out of time. I do want to mention too, we can do one more. I do want to
Thanks,
mention.
Chris.
Can I just mention one thing too? The other resource I didn't mention, the reason why I wanted to point out NACDD, they have an affiliated foundation called the Prevention Health Foundation, where you can actually be trained. They took our training materials for Prevent T2 for All and incorporated it into a lifestyle coach training. So you can actually be trained in inclusion through Prevention Health Foundation, and you'll find that link on the slides when that'll be provided to you.
Hi, Carrie Harris, University of Montana. Thank you so much for that great presentation. I wonder if you might give us a little sneak peek on DPP for people with intellectual disabilities. What are the components that you expect are needed to be adapted? And maybe you're not the right one to ask that question, but any sneak peeks?
I'm not sure we have any yet.
Darn it.
What we are going to do sort of an addendum to our Prevent-T2 for All that will focus more on people with intellectual disabilities and sort of the how to operationalize working with folks from that population. But it's really a lot of videos. We're going to be working with actors with intellectual and developmental disabilities to be in any media and production that we have. So it'll be a lot more visual, a lot less reading, I hope. So if you're familiar with the current sort of Prevent-T2, even though they've tried to sort of trim it down over the years, it still is a lot of reading, a lot of comprehension. I think there's still even things that you could consider homework in the program. So we're going to be trying to address all of that. And right now, the timeline is next summer. So we just started. So,
Can I
but
add
stay
something
tuned.
Too, that what's interesting about the challenges in adapting and making these programs inclusive, programs like diabetes prevention program is evidence-based, so the content can't change.
Right.
It's the promotion of the program. So outreach is done for the groups with health disparities, like people with intellectual disabilities. So outreach is different and the delivery may be modified, but the content stays the same.
Right.
And the expectation is the health outcome improvements will be the same. And that's the accountability piece. The other thing we'd like to see is if there's 3% of the population considered having intellectual disabilities, we'd like to see 3% of the graduates from the program be in that group. So it's not just inclusion, it's intentional inclusion that produces outcomes that are quantifiable. So, but glad you asked that. Thanks.
And when we did Prevent-T2 for All, we actually went kind of all the way and said, CDC, this is the way that people with intellectual disabilities in particular can be incorporated. You really have to simplify things. And they told us we couldn't do that. So we had to kind of pull it back a little bit. Now we're with Special Olympics, we're kind of approaching it and kind of dragging them, not dragging, but we're bringing them along and kind of showing them this is what we're doing and why we're doing it. So, all right.
And I think that's really a good thing, because the research showed that it was beneficial, but they need to work on this, because if it's only beneficial for a certain part of the population, it's not a good thing. And I was wondering, in Montana, how many DPP programs are on Indian reservations?
The answer was 6.
Oh, 6, okay. So that's almost every reservation. I'm not aware of one in Browning. Oh, well, I'm the board chair for Fast Blackfeet. And ours is not a certified diabetes prevention program, I don't think. Not one that has standards of care and that we can bill for and all of that stuff. Say again.
I'm going to run this really quickly. And maybe what we can do, is it okay if I just kind of call a break for this? Because I think it's a really important question. I'm going to say, just to add to the bubbles that Chris has, attitudes, right? Cultural humility, having a real sense that we do need evidence-based, but we also need to have some cultural humility as we do this work. And yeah, Noni.
The reason for my statement is that Fast Blackfeet's DPP program, the funding came through Rocky Mountain Tribal Leaders. And there's been some discussion about the year-long and the number of times people meet. I'm a registered dietitian and I worked in Indian Health Service for 30 years. And so I know what kind of time you need to have with people in order to change their lifestyles. But basically, because it's evidence-based and all of that, it doesn't work really well for Indian people because there's a lot of difficulty with being with something for a year and attending this and attending that. And so you have a unique kind of person that can jump through all of those hoops, and it's not the majority of Indian people. So I know we're not talking about that, but there are Indian people who are disabled intellectually and other, and so they have a double whammy there, you know.
And adherence is something that CDC has been trying to address for everybody, really.
Thank you both for those comments. This is the purpose of the summit, right? I think that inclusion is not always a strict checklist of here are some ways that we take content that is evidence-based and we make sure it's available to other folks. We have to really be thinking with other folks about the content they need. And so I'm so glad for that question, Noni. And I'm so glad to let everybody have a break right now. Our food is here. So for folks who need a little mid-morning snack and or a little space just to think about the wonderful information that Chris Mackey shared, let's take that pause now. And Erin, when should we kind of reconvene? Do you get us back on track? 10:40? Okay, great. And then just one inclusion tip. If you're not aware of how QR codes work, you can take a smartphone or ask a friend with a smartphone to hover over the QR code. And in our program, it will take you to bios of our presenters. And it also, there's a QR code that will take you to the live captioning that's happening on the screen in front of me. So if you need that text that's coming through our live captioning service on your smartphone or on your other device, you can use the QR code to link to that support. And that's pretty much it. Chris, any final comments before we break?
I would just say inclusion isn't optional. Please treat this as mandatory, okay? This is a justice issue, right? Please treat this as mandatory. That's it.